I was thinking about how we usually, how we treat the neck, like in med school or even just in, casual conversation. It's always treated like this conduit.
Right, just a simple cylinder.
Yeah, a pipe for air and food and maybe a place to hang your scarf.
It's the pivot point, the thing that lets you turn your head.
Exactly.
But functionally, we tend to just completely overlook how much is actually packed in there.
It's incredible because when you actually open the hood, when you look at the source material we have for today, that whole simple pipe theory just falls apart instantly.
Oh, absolutely.
I mean, you could argue it's the most high stakes, high density real estate in the entire human body.
It really is. It isn't just a connector, it's a packed highway during rush hour.
Yeah.
You got air going down, food going down, arterial blood pumping up at high pressure, venous blood draining, and then all this information. These incredibly sensitive nerves, all competing for space.
And the margin for error is what, millimeters?
It's basically non-existent.
So that is our mission for this deep dive. We are not just listening parts today. We are going to map out the wiring of the human voice, specifically the laryngeal nerves. And we're going to trace the very, very strange evolutionary detours they take.
And they look like massive design flaws at first glance.
They really do. And then we'll decode the body's alarm system, the lymph nodes.
Including one with a very mysterious name.
Right. But for you, the listener, the goal here is to get past just memorizing things. If you just memorize where a nerve is supposed to be, you're going to be lost when things are different.
Exactly. But if you understand why the anatomy is the way it is, the logic behind it, then you really own the material.
So let's start with the wiring. If I want to speak to you right now, or a singer wants to hit a high C, there's a signal traveling from the brain down to the larynx. Who's the main player here?
The parent cable, the absolute heavy hitter of the parasympathetic system, is the vagus nerve.
Okay, the vagus.
Now, the vagus wanders all over the body. It hits the heart, the gut, everything. But for the voice, we're really interested in two specific branches. And the first one is the superior laryngeal nerve.
The SLN.
The SLN comes off way up high from the inferior ganglion of the vagus nerve. And it starts its journey in this really protected spot, descending right behind the internal carotid artery.
So it's tucked away deep, riding down the neck behind that.
Behind the blood flow, exactly. It's safe there.
Yeah.
But according to the texts, there's a very specific landmark, a geographic coordinate really, where this nerve just hits a fork in the road.
Ah.
This is a critical moment for the SLN. It travels down to the level of the greater cornua of the hyoid bone.
Let's just visualize that for a second. The hyoid is that little floating U-shaped bone, right? Up under the chin.
That's the one. And cornea just means horn.
A horn, okay.
So at that specific bony point, the nerve splits into two completely different branches with two completely different jobs. You get an external branch and an internal branch.
Okay, let's break that down because that seems huge. What's the external branch doing?
Think of the external branch as the motor wire. It's all about action. It travels down and supplies the cricothyroid muscle.
The cricothyroid.
And that's the muscle that tenses your vocal cords.
So if I'm a singer, or if I raise the pitch of my voice to ask a question, that's it. That's my pitch control.
Precisely. It stretches the cords, creates higher frequencies,
Right.
and it's the only intrinsic muscle of the larynx that this specific nerve supplies. It's the outlier.
Okay, so that's the motor, the action. What about the other side of the fork, the internal branch?
The internal branch is the sensory wire. It doesn't move a thing. Instead, it pierces right through the thyroid membrane, that sheet between the thyroid cartilage and the hyoid, and it provides feeling sensation to the larynx and the hypopharynx.
So external acts, internal feels.
That's the shorthand, yeah. The internal branch is what tells you if a crumb went down the wrong way. It's the watchdog for your airway.
Now, this isn't just academic. There's a really practical reason for knowing exactly where that fork is. The sources describe a superior laryngeal block. Why would a doctor need to do that?
It's usually for pain control or anesthesia. Maybe for a procedure on the vocal cords or an awake intubation where the patient has a difficult airway.
Oh, wow.
Yeah, you need breathing on their own, but you can't have them gagging and coughing while you work. So you have to numb that sensory wire.
And you can't just guess where it is. You can't just poke a needle in the neck and hope.
No, you have to be incredibly precise. The protocol is fascinating. It's pure geometry. You position the patient with their head and neck extended.
You're unfurling the map.
Exactly. Then you find those bony points. You feel for the greater horn of the hyoid, and you find the superior horn of the thyroid cartilage just below it.
So you have 2 points on your map.
You draw an imaginary line between them. Now, you might think you inject right on that line, but you don't. The target is about 1 centimeter anterior so toward the front from the midpoint of that line.
That is so specific. 1 centimeter forward.
It has to be. You insert the needle there, inject about 2 milliliters of 2% lignocaine, and if you hit that sweet spot, you've blocked the internal branch.
Yeah.
You've numbed the larynx above the vocal cords.
That's amazing. Just pure geometry saving the day. But the superior laryngeal nerve is, well, it's the straightforward one.
It really is.
It goes down, it splits, does its job. We have to talk about the other one. The one that confuses every single anatomy student.
The recurrent laryngeal nerve, the RLN.
Recurrent, it comes back.
Yes, it runs down, makes a U-turn, and comes all the way back up. But the thing that drives people crazy, and what's maybe the most interesting part of neck anatomy, is the asymmetry.
Right, the left and the right sides are not mirror images, not even close.
They're doing two totally different things.
Okay, let's walk through this. The right side first. That's the shorter journey, right?
Relatively, yes.
Yeah.
The right RLN branches off the vagus right around the subclavian artery near the collarbone. It hooks around that artery, loops under it, and then starts climbing back up the neck.
Where does it sit on the way up?
In that little groove between the trachea and the esophagus.
Okay, so it hooks around the collarbone artery, a tight loop. Makes sense.
It's efficient enough.
Yeah.
But the left side is taking the scenic route.
Yeah.
It doesn't stop at the collarbone. It keeps going down deep into the chest, into the mediastinum, all the way down to the arch of the aorta.
Into the chest.
Into the chest. It loops under that massive pipe coming off the heart, and then it has to climb all the way back up, that same tracheo-esophageal groove to get to the throat.
That is a massive detour. I mean, we're talking about inches of extra cabling just to get back to the same spot.
It is significantly longer. And both nerves, they eventually arrive at the same place. They enter the larynx behind the cricothyroid joint. But the left one has run a marathon to get there.
And let's just nail down the function here. The superior nerve handled the high notes. What does this recurrent nerve do? Why is it so important?
It does all the heavy lifting. The recurrent nerve supplies all the other intrinsic muscles of the larynx.
So everything else.
Everything. If you want to open your vocal cords to breathe, close them to speak, that's the recurrent nerve. Plus, it handles all the sensory input below the vocal cords.
So if a surgeon nicks this nerve, let's say during a thyroid surgery or maybe even heart surgery near the aorta,
It's a catastrophe. You could end up with a hoarse voice, a whisper, or in a bilateral injury if both sides are damaged, you could lose the ability to open your airway at all.
Wow.
You'd need a tracheostomy just to breathe.
which brings us to that aha moment. Why? Why on earth does the left nerve go all the way down to the heart? from an engineering perspective, it's terrible design.
It looks like terrible design if you only look at the adult. If you were wiring a house, you would never ever do this. But it's not bad design, it's just history, it's embryology.
Okay.
You have to remember, we don't start out shaped like this. In the embryo, the heart starts very high up, right near the neck.
So in the beginning, the distance is short, the nerve just has to hop over the vessel.
Exactly. During development, you have these things called aortic arches, loops of blood vessels, and the laryngeal nerves get hooked around the 6th aortic arches. As the embryo grows, the heart descends into the chest, it moves caudad toward the tail.
And the nerves are hooked on, so they get dragged down with it, like an anchor dragging a line.
They are tethered. Now here's the crucial difference. On the left side, that 6th aortic arch stays. It becomes the ductus arteriosus, which later turns into a ligament. Because that structure sticks around, the nerve stays caught on it, low in the chest.
It's trapped.
It's trapped. But on the right side, the 6th arch disappears. It resorbs. So the nerve is momentarily free. It slides up until it hits the next available catch, which is the 4th aortic arch. And that becomes the subclavian artery.
That is wild. So the left nerve is trapped by a vessel that stays, and the right nerve slides up until it hits the collarbone artery. That explains the asymmetry perfectly.
It's a ghost of our development. The anatomy is just a recording of how the heart moved.
But speaking of ghosts, sometimes the blueprint changes completely. And this is where it gets really dangerous for surgeons. The sources mention a non-recurrent laryngeal nerve.
Yeah, this is a rare one. Less than 1% of the population, and it's almost always on the right side. But if you're a surgeon, you have to know it exists.
What happens here? The nerve doesn't loop.
Not at all. It branches directly off the vagus and shoots straight across the larynx. It's a straight shot.
And why would that happen?
Well, remember how we said the nerve slides up and gets caught on the 4th arch, the subclavian?
Yeah.
In these rare cases, the right 4th arch also resorbs. It disappears too. So now there's nothing for the nerve to hook around.
Wait, if there's no subclavian artery, how does the arm get blood?
The body finds a way. The right subclavian ends up arising from the descending aorta much later on. But because the hook is gone, the nerve isn't dragged down at all. It just takes a direct path.
That actually sounds more efficient. Why is it a problem?
It's an ambush. A surgeon operating on the thyroid, they're trained to look for that nerve coming up from below, from the groove. They are not looking for a nerve coming straight across from the side.
Oh, I see.
And it often crosses behind the common carotid artery. It's completely hidden.
So you're dissecting, you think the coast is clear because you haven't reached the groove yet, and snip.
Exactly. And that's why understanding these anomalies is life or death. You have to be ready for the exceptions.
And on the subject of danger zones, there was one other red flag in the notes that I have to admit it scared me a little. The laryngocardial reflex.
This is a potent reflex. The larynx isn't just a box of cartilage. It's wired directly into the vagal system, the autonomic control center.
So what happens?
If you apply too much pressure over the larynx, maybe during a difficult intubation or aggressive retraction in surgery, it can trigger this reflex arc. The signal shoots up to the brainstem and fires right back down to the heart via the vagus.
And the vagus nerve is like a brake pedal on the heart.
A very aggressive brake pedal. It causes bradycardia, a severe slowing of the heart rate. And in some cases, it can cause full-on cardiac arrest. The heart just stops.
Wow.
It's a stark reminder that when you manipulate the neck, you are interacting with the control panel of the patient's entire physiology.
Okay, let's widen the lens a bit. We've done the wiring, the electrical hazards. Let's talk about the defense system, the lymph nodes.
Right. The neck is the primary drainage basin for everything in the head and face. If there's an infection, or worse, cancer, the neck is where it gets caught.
And there's one node in particular that stood out. It has a name that sounds like something out of a Greek myth, the Delphian node.
Also known as Poirier's lymph node.
Where is this thing?
It's right in the midline, anteriorly. It sits just in front of the cricothyroid membrane, that little soft spot in the middle of your throat.
So why is it so special? Why does it get a cool name?
Because you shouldn't be able to feel it. It's very rare to find it enlarged. And if you do, if you find a palpable Delphian node, it is almost always a herald of bad news.
Like the Oracle of Delphi delivering a bad prophecy.
A very bad prophecy. It suggests a poor prognosis. It's often associated with glottic carcinoma or advanced tumors that have spread down into the subglottic region.
So if that one specific node pops up, it tells you the disease has already broken containment.
Essentially, yes. It's a big red flag waving right in the front of the neck.
And speaking of containment, the sources had some really interesting stats on metastasis cancer spread, depending on where in the larynx it starts.
This is a crucial distinction, yeah. The larynx has levels. You have the supraglottis, the upper part, and the glottis, which is the vocal cords themselves. If you have cancer in the supraglottis, the risk of it spreading to the neck nodes is very high, something like 60%.
Wow, more than half the time it's already on the move.
But if the cancer is on the vocal cords, in the glottis, the risk plummets. It's only about 10%.
60 versus 10%, why such a huge difference?
It all comes down to lymphatic drainage density. The vocal cords themselves have very, very sparse lymphatic vessels. The upper part, the supraglottis, is rich in them, so the highway for cancer to get out is just wide open up top.
So the anatomy dictates the behavior of the disease. Now, when doctors are feeling for these nodes, size matters, doesn't it? When does a doctor start to worry?
The general rule of thumb from our sources is a size cutoff. For most of the neck, any node you can feel that's bigger than 1 centimeter is significant. You need to look.
Okay, 1 centimeter.
With one little exception, under the jaw and chin, the submandibular and submental areas, the cutoff is a bit higher, 1.5 centimeters.
Why the leniency there?
Because those nodes drain your mouth and teeth. They're constantly reacting to little things. Gingivitis, a canker sore, a cold. They're just reactive more often, so we give them a little more leeway.
Got it. Okay, to wrap this up, we have to talk about the zoning system. Surgeons use this standardized map of the neck, levels 1 through 7. Let's just do a quick visualization.
Sure. Think of it as a grid that lays over the neck muscles. It's all about the boundaries.
Okay, level 1.
That's the chin and jaw area, submental and submandibular triangles. The boundaries are the digastric muscles and the hyoid bone. So a lump right under your chin, that's level 1.
Moving down, level 2.
Now we're on the side of the neck, along the big jugular vein. Level 2 is the upper jugular zone. It runs from the base of the skull down to the hyoid bone.
And level 3.
Just keep going down that vein, middle jugular, from the hyoid down to the cricoid cartilage.
In level 4.
Lower jugular, from the cricoid down to the collarbone. So levels 2, 3, and 4 are just this one vertical column along the major blood vessels.
Okay, that's the main vertical strip. What about the back?
That's level V, the posterior triangle. It's the area behind that big sternocleidomastoid muscle, but in front of the trapezius on your shoulder.
And then the very center, level 6.
The anterior compartment, the central column, right in front, between the carotid arteries, hyoid down to the sternal notch. This is where your thyroid lives, and where that Delphian node would be.
And finally, level 7.
Level 7 isn't really in the neck properly. It's the superior mediastinum, below the sternal notch, dipping into the chest cavity.
It's surprisingly organized when you lay it out like that.
It has to be. When a surgeon does a neck dissection for cancer, they need to know exactly which compartment they're clearing. You clear level 2, then 3. It's a systematic operation.
So tying this all together, we've gone from the vagus nerve splitting to these crazy loops around arteries to the zoning of lymph nodes. What's the takeaway?
I think it's about predictability and pattern recognition. The body is complex, but it follows rules. The nerves follow the blood vessels. The lymph nodes follow these fascial planes.
And when you know the rules,
You can predict the exceptions. You understand why a patient's heart might stop when you press on their throat, or why their voice changes after heart surgery.
Right.
And you know that if you see a lump right in the middle, that Delphian node, you need to look deeper, because the defense system has been breached. Anatomy is the map, but embryology and pathology are the legends that help you read it.
I love that. And here's a final thought for you to chew on, listener. We spent a lot of time talking about how the recurrent laryngeal nerve is shaped by blood vessels that literally disappear before we are even born.
The ghosts of the embryo.
Exactly. And it makes you wonder, if our nerves are taking these massive, inefficient detours because of vessels that don't exist anymore, what other ghosts of our development are hidden in our daily physiology? What other parts of us are shaped by structures that aren't even there?
That is a fascinating question. We're essentially a walking museum of our own history.
We certainly are. Thanks for taking this deep dive into the neck with us.
My pleasure.
See you next time.